to family physicians and other healthcare providers. Quite a bit of it's actually at the residency level. We try filling out forms and just having a good understanding of what the WSIB is, because it's not something that is taught often in the different programs across the province, whether it's OT, PT, medicine, and so we're really aim to fill that gap because ultimately our goal is, of course, to get people recovered and return to work as effectively as possible. And it's completely dependent on the excellent healthcare that you provide each day. But having an understanding of how to interact with the WSIB so that that can be really efficient so you can see in the title here how to leverage the services that the WSIB has to facilitate the recovery of patients and return to work. That's the key. That's the key goal today. That's what we're going to try and get at. So in terms of just disclosure slide here, so really the main disclosure here is that we both work for the WSIB, right? But that's also the reason why we're presenting today. And so that's really the main one. I also do a bit of consulting work outside of the walls of the WSIB, and of course my clinical practice at St. Mike's Unity Health. Okay, so the learning objectives, by the end of these rounds, you should be able to explain what the WSIB process is to patients. And this is specific objective because it's important for all of us to understand how the system works, but for our patients, they often have a lot of questions. And so the better we're able to answer the questions of the patient, that really builds that understanding and is the best way that they can feel comfortable within the system and system navigation and knowing that really the WSIB is there to help them recover and get better. Because oftentimes patients sort of view the WSIB as it's an insurance. It's like any other insurance company. But of course, it's quite different. It's an agency of the government. It's not profit driven. At the end of the day, just need to balance the books. And the entire mandate really is to assist in the treatment and the recovery of patients. So just being able to educate our patients on how the WSIB works is an essential skill for any healthcare provider. We'll also describe the continuum of care offered by the different WSIB healthcare programs, and that's important to understand so that you can leverage those programs effectively for your patients, because there are benefits over and above those that are offered just through OHIP. So we'll talk a bit about that so that you have an understanding of the programs and how you can leverage those for your patients. And that really is the third objective as well, really working with the system and understanding it so you can leverage it properly. Okay, so this is really WSIB 101, and it may be review for some of you. Essentially, I like to go back to when the workers' compensation system was set up, and that was in 1914. And Ontario had the first workers' compensation system in Canada. And before workers' compensation came into effect, it was really the whole system was tort law based, right? So if somebody got injured at work or even developed a disease, and interestingly, the act right out of the gate addressed occupational disease as well, which is quite fascinating. But before the act came into place, essentially the only recourse a worker had if they got injured was to sue the employer. And as you can imagine, oftentimes that wasn't successful, and that person might have a permanent impairment, not be able to work, etc., and really no safety net to assist them to find new work, to get better, and to have loss of earnings paid, etc., because when they weren't working. So it wasn't a good system for workers. It actually wasn't a good system for employers either. So employers, even though they usually would win those lawsuits, If they didn't, the damages could be quite substantial, and actually put them out of business. So it was not a good system. So what this gentleman did, Sir William Meredith, was he was tasked with going around to look mainly in Europe at workers' compensation systems, and he came back and said, "We need to establish this workers' compensation system, and it really needs to be based on this historic compromise." So the compromise was that uh, workers give up the right to sue. So if they get injured at work and they're covered, then they aren't allowed to sue the employer. In exchange for that, they get guaranteed benefits. The employers, on the other hand, they are protected from lawsuits. That's their benefit. But in exchange for that, they have to pay into the collective liability system. So that's the historic compromise. If anyone ever asks you about what's this workers' compensation based on, it is that historic compromise. So now what we see is just over 70% of people of workers in the province of Ontario are covered by the Act. That's a very common question that we get. Who's covered? How do we know if somebody's covered? And it's not actually that easy a question to answer because the Act isn't exclusionary. It doesn't say everyone's covered except it actually says these industries are covered. And so there are some specific areas of work that are not covered. Some of them are quite specific, like circus performers or professional sports. I think shoe shiners are in there. There's some other very specific things. But for the most part, and also independent contractors, unless they're construction, don't tend to be covered. They can always elect for coverage and pay into the system, but about just over 70%. And so if I always say if you're not sure if a patient's covered, then you should still file a claim, and the WSIB, they will figure it out and say they're supposed to be part of a covered industry, but the employer hasn't been paying. The WSIB will also take care of that. The person will be covered, and the WSIB will then, work with the employer to establish the them paying into the system, etc. So we talked about the historic compromise. These Meredith principles really speak to that historic compromise, but also the fact that as in other jurisdictions in Canada, the workers' compensation system has exclusive jurisdiction. So there's just one, right? It's the WSIB. It's not like in south of the border where you might have multiple different insurance companies involved. Just single workers' compensation system. It's no fault. So if somebody chooses not to wear their hard hat and gets injured at work, that's still covered. They have security of benefits, the collective liability, all the employers are paying into that system, and it's coming out of that pool of money that is based on a certain amount of premiums being paid by employers, roughly, about $1 per $100 of wages. Exclusive jurisdiction. So the WSIB has exclusive jurisdiction over the decision making process, but also in terms of managing the funds. So, if claims go up by 50% 1 year, then they'll figure it out on the books, and the premiums will go up to basically balance the books. And independent administration. So the other question that's often asked is, well, is this a political entity? It's a government organization, but it's an agency of the government, so it is independent of that political process in that sense. And the last thing is that everything the WSIB does is governed by the Workplace Safety and Insurance Act. So the WSIB is really responsible for implementing the Workplace Safety and Insurance Act, and that's where its mandate comes from. It's similar, on the other side of the fence is the Ministry of Labor, Immigration, Training, Skills Development, or Ministry of Labor, people still sort of just refer to it as. And its sole purpose is to administer the Occupational Health and Safety Act. So those are the two main acts when it comes to occupational medicine, and the WSIB is responsible for the Workplace Safety and Insurance Act. So this is the mandate, as I was referring to, and it's actually quite interesting, again, because patients and the general public often thinks initially of the WSIB as just an insurance organization. But if you look at the actual act, it spells out four pieces of the mandate, and there's only four. But the first one's actually promoting health and safety in the workplace. The second one is facilitating return to work and recovery for patients. The third is work transition. So if somebody has a permanent impairment, they can't return to the accident employer. They need assistance in retraining or transitioning to a new third mandate. And it's actually the last mandate that's listed fourth is the compensation and benefits. But we will be focusing today on those benefits really so that you can understand what's going to be most relevant.
Are we all frozen? Just Dr. Thompson?
I think he's maybe,
I'm frozen. I'm gonna text Aaron right now.
did you want to take over, Jesse? Do you know?
I'm sure it'll be a surprise, but I can certainly. Let's see if we can get him. I can message him internally here. Uh-oh.
Oh,
he
he's
logged off and on.
He's popped off, so I imagine he figured it out. Jesse, have
Okay.
you been able to reconnect with Aaron?
Haven't heard from him yet, but it looks like he's online, so I don't think he's totally lost connection.
Okay.
I can share if you want to take over, Jesse, for a few minutes.
Oh, there you go.
Oh, is
He
he?
should be there. He said, yeah, perfect.
Technology, it's a wonderful thing.
It's not a real presentation unless you have a tech issue these days.
Sorry about that. I was reading about the solar interfering or something yesterday. It was on CTV News. Bell went down as well. So I don't know. I'm back. Everyone can see and hear me?
Yes, we can.
Okay, great. I'll reshare my screen, but I think, Kath, you're gonna have to give me the screen sharing ability again, I believe. Are there any questions at this point while I get this back up and running? I don't see any. Okay, feel free to put up your hand if you have any questions. Also, put up your hand if I'm boring you or it's I'm going too slow or too fast. Okay. Good. So I was just getting to this point where talking about the number of claims, and this it's actually it's remarkable to me every time I see it. 2024 actually had a lower number of average claims. Usually it's around 200,000 claims a year, and you can see that a lot of money flows through the system too. Over $2 billion in benefits. And the other thing I'd like to highlight on this screen is that the scope of coverage. So, of course, traumatic injuries are important and physical injuries, but there's also a large number of occupational diseases, and that could really relate to any disease that work has made a significant contribution to. So there is a specific list that, like, in terms of common occupational diseases, but it goes well beyond those on the list. And mental stress claims. So mental stress coverage for mental stress injuries has really increased. Historically, if there was a traumatic incident, somebody's involved in an assault in the workplace, or a robbery, something like that, those were always clear cut. But there's been this increased recognition of cumulative mental stress. And that's even expanded into the legislation where there's presumptive legislation. In other words, the claim is accepted if the person has the diagnosis and works in that occupation. So first responders and PTSD is perhaps the best example. And that, of course, includes nurses as well. So these mental stress claims are increasing, appropriately so, with increased recognition, and they make up an important component of the claims. And we'll talk about the healthcare programs and the coverage and supports for patients with mental stress injuries. Okay, here's the interactive component. So put into the chat A, B, C, or D. I just want to make sure that everyone's that I'm being clear here. So let me see if I can get that chat open. So what do you think here? Is the WSIB a private insurance company, or is it part of the Ministry of Health and Long-Term Care, or is it a national, or is it provincial government agency? Oh, here we go. Oh, yes. All right. Thank you so much for the interactivity here. And everyone's got that one right. So, okay, that's good. Start with a bit of low-hanging fruit on that question. Okay, so the other thing I'm going to address before I pass things over to Jesse, the life of a claim. So patients are often very interested, well, what happens when I file a claim? And so if this is a very simple schematic, and it looks linear here, in the latter portion, these things are usually happening concurrently as well. So at claim registration and intake, essentially there's a 5-point check system. So people are always interested to know how does a claim get registered, and what goes into deciding if it's accepted. So the claim registration process is actually, in Ontario, it's based on the report from the worker and the report from the employer. Either of those will trigger a claim. So the worker fills out a Form 6, the employer a Form 7. The duty to report is actually on the part of the worker and the employer. So when somebody gets injured at work, they are supposed to let their employer know, and the employer has a duty to report and file a claim. So if either a Form 6 or a Form 7 come into the board, a claim is immediately established. So the common question that is asked is, well, what about me as a healthcare provider? Do I have to report if I know that this person's injury is work-related? And interestingly, Ontario, and I say this is very specific to Ontario because it's a bit different in some of the other jurisdictions, but in Ontario, you as a healthcare provider do not have a duty to report the workplace injury or file a Form 8. And a Form 8 actually in and of itself doesn't actually establish a claim either. What is our duty? Our duty is, if a patient asks us to fill out a Form 8, then we have to do so. And of course, it's in their best interest to file a claim. And so we don't have a legislative duty, but our role really is to educate the patient as to why they should be filing a claim if they're reluctant. And we can talk about that scenario and how to have that conversation. But our duty specifically from a legal standpoint is that we fill out a Form 8 if the patient asks, and we do need their consent to file that. And so that's important for all of us to understand as healthcare providers. The other important thing here is you don't, if you're unsure if it's work related, so let's take an occupational disease example, you might not know if their hepatocellular carcinoma was caused by an exposure in the workplace, right? These are difficult causation analyses that need to be done. But importantly, you don't have to. So all that expertise is within the WSIB. There's industrial hygienists, there's occupational medicine physicians, there's the programs, the specialty programs, etc., that we're going to talk about to figure that out. So, and the other thing is, you might not actually think something's work related, but if the patient's asking you to fill out the Form 8 and they think it's work related, then you do so. And then once that information comes into the WSIB, they will figure out, you know, they'll make sure the person is covered. They will use the experts around them to do the causation analysis. They will be involved in the return to work process and with return to work specialists, etc. And they'll also, they don't direct care, so the WSIB does not direct care, but it will help with system navigation and make decisions on, you know, the appropriateness, reasonable and necessary treatment interventions. Okay, the next thing is the entitlement, and this is it's very straightforward, but of course there's complicated cases. But even the most complex cases follow the exact same 5-point check system. So the 5-point check system, when you hear that referred to, is when a claim comes in, what that case manager is doing, that adjudicator is saying, all right, is this an employer that's covered under the Act? 2, is this person a worker? Are they an employee of this employer? And then the last 3 are the important ones here. So is there proof of injury? In other words, do we have a diagnosis? So if it's like knee pain, that wouldn't really be specific enough as a diagnosis. You'd need this specific diagnosis to be able to adjudicate it. Is there proof of accident? So, you know, do we, is there, did the accident happen? Is that reflected in the records or other information that's come in? And then the 5th part is the one that can be difficult in a complicated claim. Is there compatibility between the injury and the accident? If somebody has a slip, trip, and fall and they get a fracture, that's of course an easy compatibility decision. But again, say like if we take an occupational disease, let's say COPD, did that person have sufficient exposure in the workplace to particulate matter, for example, to be the cause of their COPD? That's a more difficult causation analysis. But even for the complicated claims, it's still the 5-point check system. And particularly on that compatibility piece, again, there's many resources. Industrial hygienists to do the exposure assessment, retrospective exposure evaluations, and quantify the exposures that took place in the workplace, etc. And then there's occupational medicine physicians to provide, you know, review the literature and provide opinions on the compatibility or the causation. And when it gets down to questions about diagnosis, then the specialist can also be leveraged to inform that. Okay, Becky, you have a question?
I have a question, yes. What about for repetitive strain injuries? There's not really an accident per se.
Yeah, so when you think about accident types, there could be acute exposures. So a single incident, so an ergonomic setting, you know, force, repetition, posture. And so then the cumulative, so what you're asking about is repetitive strain injuries. So in that setting, the accident would be the job duties over that time period. So if somebody develops a repetitive strain type injury as a result of again, the ergonomic risk factors, so high repetition, like forces involved, awkward posturing, etc., then that causation analysis will be done in the same way, taking account of the usual job duties. So as an employer, what the employer is really asked for is, do you have a job demands analysis? If not, then somebody may go out and evaluate that from an ergonomic standpoint, etc. But again, it's still the same 5-point check system, and those claims would be accepted if that employment those employment tasks were deemed to be a significant contributor to it. Is that helpful? Okay, great. And so in terms of those supports, I've sort of referenced them a few times now, but essentially the case manager, if you think about this system, the case manager is really like a judge. So just like a judge in a court, they're not necessarily going to be have an engineering background or be able to evaluate the vectors and forces in a car accident. But what they can do is they can call on an expert to provide them that information in a way that's understandable, that they can then incorporate into their decision making. So the case manager has the same role. They're doing that, and they're drawing on these resources around them. So there's physiotherapists, there's occupational therapists, there are mental health experts, including psychiatrists. There is a physiatrist lead for the musculoskeletal. There's occupational disease expertise. And so these clinical experts can assist in understanding the information for the case manager so they can make an informed decision. And then there's the return to work specialists. So those return to work specialists are essential, particularly when there's barriers that arise. Quite often it's just the employer not really having a good handle on identifying restrictions and limitations, and how those translate into potential accommodations in the workplace. And so they're all certified disability management professionals, and there's over 300 of them that will do the work site visits and work with the employer and the worker to assist in the return to work process. Okay, so of course, during all this, if the person is missing work, then there's loss of earnings benefits that are provided. The healthcare benefits extend well beyond what OHIP would fund. So even think about basic things like physiotherapy and occupational therapy and all those resources. Those are all covered. The formularies are different, so more expansive formularies. And then the access to care through the programs, which Jesse's going to speak about, I think, right now. I'll just address the appeals process. So for any decision, not just initial entitlement, but any decision along the pathway, if an employer disagrees or a patient, a worker disagrees, then there's an appeals process that is fairly straightforward. It's people get worried, oh, it's going to be all this paperwork and whatnot. It's a form that they fill out. It goes in. It will either be reconsidered at that initial level, or if there's new information, it will definitely be reconsidered at the first level. And if not, then there's an appeals resolution officer. They will review everything and then render a decision. And if any party still disagrees with that, then it goes up to a final external tribunal called the Workplace Safety and Insurance Tribunal, or WSIAT, and WSIAT will review everything in detail, and they have their own experts to do so. Okay, so I hope that was helpful from a kind of WSIB 101 perspective, and I'm going to pass things over now to Jesse, who's going to tell you all about these programs that that can be helpful for your patients.
Excellent. Thanks, Dr. Thompson. And that was a great 101. We need to have you come to all of our provider meetings too and do that. Really well said. So this is our favorite slide in healthcare at WSIB. This is our healthcare continuum. I'll start off by talking a little bit about why we're in a unique position. As Dr. Thompson alluded to, we are a direct payer of healthcare. So because of that, we can develop our own programming, which has unique benefits. So we really work closely with experts in clinical care, as well as healthcare associations to build out programs and services that form this continuum. With the key feature, again, with the focus on not just recovery, but that return to work and that occupational lens. So we want to make sure that our programs are customized to support our clinicians and healthcare providers in the community, but also fitting within this very unique context and goals at WSIB. The biggest feature with our continuum that I'll highlight right away is that, and you can see by the circular design, it's not intended to be linear. So it's not like everyone's going to start in the same place and follow through that pathway. We really want to make sure that that injured person enters where they can get the best care, so right care at the right time. So thankfully, we see a lot of more minor injuries, sprain, strain. So we could see someone just getting some physical therapy in the community and getting back to work. But then we see more significant injuries or maybe significant trauma and a mental health injury. So sometimes those individuals go right into our hospital-based specialized care services and then step down into community when they're getting better. Good news is that over 80% of people who have got an injury at work and need healthcare, they get better, return to work with just those community services. So we really focus on that first line of care to help support. So our community programs, we have the first bundles. We kind of have 3 bundles of care within our continuum, but the community programs are our first bundle of care. We call these programs of care. So they're bundled evidence-based programs, and we say that they're the mandatory first line for those injuries that are suitable. And then from that, we have the 2 other components. So our occupational health hub, which is a hospital-based contracted service, which really focuses on a physician-led assessment or consult, but this is more of a triage or support and education for return to work. And then our last dark blue circle, specialized recovery services, which is our specialized hospital-based services. So specialists delivering interdisciplinary assessments, interdisciplinary treatment, and a lot of different pieces within that we have available. I'll go into all those details as we work through. As noted at the beginning, we have embarked on a whole refresh, and that's why it says new healthcare continuum of the full programs. And we started with the community, knowing that majority of our people do get services there. So if we go to the next slide, I'll dive in a little bit into that first line of care. So our biggest use program is the musculoskeletal program of care. So again, the mandatory first line program for all suitable MSK injuries. A lot of sprain strains go into this program. It's an 8-week program with the option for additional care as needed. But this program was recently redone. So in 2023, we did a refresh, really with keeping in mind how we can make it easier for providers to deliver it and for injured people to access. Again, because a majority of people get this service as soon as possible after injury, we want to make sure that access point is quite easy. So we see OTs, physios, chiros, kinesiologists delivering this program, and again, within community close to home. Prior to this program, we had 4 different streams, different injury types, all essentially doing the same thing, but what it caused was a lot of administrative burden, lots of different reporting, lots of different requirements. So with this new program, we streamlined everything to make it easier. Another key feature of what we did here, again, with that emphasis on getting earlier care, is that individuals can enter the program before we at WSIB make a claim entitlement decision. So that first 4 weeks of physio or chiropractic care for these more straightforward injuries can go ahead right away while we're making our decision. And we've seen incredible impact. It says 20% faster access to care since then. I think it's closer to 30% now. So really achieve people getting in earlier. And with that, we saw an increase in return to work outcomes. So moving to about 94% after that 8-week, getting back to work. So that means not having to go into specialized services, getting that early care right away. So this is kind of accessed, because I think important to address how it's accessed almost behind the scenes. Us at WCB will tell injured people when they've registered a claim, when we've made contact, even in their initial letter, it will let them know about this program to say, go into your local community, go to your physiotherapist, and most likely we have over 6,000 providers delivering this across the province, most likely they're going to be delivering. I did check Westbury Sound Health Center, and that is delivering. There's a physiotherapist delivering the program, so that's great news. We've got a really great reach, almost doubling our providers with this new program. And then we also introduced, so what we saw, so many people, I'd say about 40,000 people enter that program per year. What we saw was a little bit of a gap though. We saw some people who needed community care, but more complex. And how we define that is maybe post-surgical, maybe it's work hardening, more of a specialized expertise, maybe it's hand therapy that is beyond the scope of that MSK program of care, but perhaps they don't need that hospital level service. Maybe they're having surgery in their local community with their local community orthopedic surgeon. So we introduced what we call the interdisciplinary team program of care to help solve that gap. So we did a contracted program for this, but we still achieved really great access. But what that allowed us to do is have mandatory requirements and levels of expertise to be able to treat these more specific and unique areas. So we saw that actually allow people, again, staying close to home sometimes is better and close to work. So it could be really integrated and return to work and getting that treatment at the same time. And then finally, within our programs of care, we have our MTBI program of care. Dr. Thompson, I feel you should talk to this one because we've seen incredible outcomes with this. Before this, so this launched revised at the end of 2020. And really the revision of this program was to align with what concussion care looks like. We know that the evidence base and what was best practice and what intervention should be included was a lot different than the program that we currently had. So with the inclusion of things like exercise therapy, vestibular rehab where it's required, we've seen, first of all, great uptake and early uptake with people getting this treatment as soon as possible after they have that head injury, and really great outcomes. So savings of 20% in terms of healthcare and loss of earnings because they're not moving into, again, that hospital specialized care with the right interventions close to home. And again, this program acts the same way. There's a directory behind the scenes. Somebody will be told from WSIB, this program exists, you go into your community and find someone who delivers it. I will look at this question. So does it interfere with your process for the MSK program of care if we were suggesting referring the patient to PT, the first point of contact with the Form 8 prior to sending the letter or contacting the patient? I presume we shouldn't wait for you to refer. Yeah. That's a great question. You can let them know because they should be getting, and with that barrier removed that we don't need claim entitlement. So maybe it is when we're getting your Form 8 and everything else, we would be telling them you can go ahead and access that we don't need to make that claim decision. So that's great if you're recommending it. Now you know that you could even direct them to the WSIB website. They can find a provider that delivers this program. Okay, so in terms of mental health in the community, so we have the community mental health program. So this is solely delivered by psychologists. We developed this program in 2018, and the biggest goal of it was to expand access. We didn't actually have access to psychologists in the province. It was very limited. And to be honest, not that many people wanted to work with us. So a huge win of this program is that we did get provincial reach with over 6,000 psychologists delivering this service. We followed the same fundamentals, and that it's a bundled block program, evidence-based practice, and then specific reporting. And again, with mental health, and Dr. Thompson spoke to this, even more challenging when we're looking at abilities and limitations and getting that occupational rehab lens. So we've created forms to help support those psychologists in delivery of that. This is actually the program we're going to be looking at this year. What we've realized, and again, to Dr. Thompson's point, lots of claim increase within mental stress injury program. So we see a significant use, and we know there's a lot of different mental health professionals, such as psychotherapists, occupational therapists, that are involved in care, but this program doesn't allow for them to deliver currently. So we want to actually expand it to include those other professions, make sure we're in line with the best evidence, and put some different accountabilities in terms of the expertise required. We know that each unique subset, trauma versus a secondary depression to a physical injury, all different requirements for those healthcare professionals. So we're looking to adapt this program and roll it out by the end of the year to, again, try to get better access and align with some of the pain points we see. Okay, so that talks about our community services. So again, majority of people going there, which is good news story. But we do have about 10%, I will say, out of everyone who needs healthcare, who do need more specialized care services. So historically, we called, if you're familiar, we had OHAP and we had specialty program. We redid these programs at the end of 2024, and we used slightly different names, but not so different that it's not confusing everybody. But essentially, with some key changes, the same intent. So we're fortunate enough to contract with 15 hospital partners. And what's unique about some of those contracts is those hospitals subcontracted with others. So we saw a really great range across the province, and new hospital partners came to the table in delivery of these services. So I'll speak a little bit about Occupational Health Hub. So our main goal here, and change from what was current. So again, this is a physician-led service. We require expertise in occupational rehab, and it's really to help support return to work, education, and help us at WSIB triage to the next steps. So generally, this is something that would be used early on in the case to understand and help us navigate where we're going to go. What we saw in our old world is that a lot of people had an assessment within that program, and then they went on to the specialty program, hospital-based care, and we saw duplication of assessment. So with this refresh, what we decided within OHUB is that we're going to have a virtual assessment. So that occupational rehab physician will do a virtual assessment. We saw really great success with something we trialed during the pandemic because no one had access to family doctors. People didn't have access to anything. So we did a virtual option to allow a physician to help us get a Form 8 and get a claim registered. But we also added in support with the return to work specialist, a conversation with the return to work specialist, kind of that reassurance and education. And we saw really great results, and it got that injured person on board and to the next steps. So this is a permanent feature now within OHUB. And there's a few other pieces, a few other different types of assessments, but this is what we're seeing as that triage option to help us understand next steps. So one piece of the assessment services, other unique assessment services within OHUB is complex medication review. This is a physician specialist and a pharmacist. We do have a lot of people who have complex medication histories and maybe no other recovery challenges. So they don't need to go to a specific specialty program for, say, lower extremity, but they do want to use that to review their medication. So this is an option within this program. We have migrant worker assessment. So goal is make sure we have an assessment ASAP. A lot of these people are being repatriated. So we'll really focus on getting that assessment done with recommendations within a tight timeline. And then non-economic loss assessment for those individuals who have permanent impairment, and we're determining that ongoing payment. And then aside from assessment, we have consultation services. So case consultation, essentially a file review if we have a very specific question in the claim. There's always the option for in-person if that is required, but essentially for very specific question, not related to adjudication, that we can ask. Cannabis case consult is an add-on. We do have some individuals where we have a specific question regarding their cannabis use. So we've added this in as an option within this. Okay, great. So then our last piece is then our specialty program, Specialized Recovery Services rebranded. Really, they were working really well. We have 10 different programs. So our MSK injuries, upper, lower back and neck. Then we have mental health, neurology, and then very specific programs like amputee, burn, occupational disease. But these were working really well. What we wanted to focus on was our pain points to expand and to make them better. One of our biggest pieces, again, over the last 5 years, big strain, and what we heard from our hospital partners, big strain on resources. So we didn't want to limit people to getting these services when needed, but we didn't want to have mandatory requirements as much. We wanted to give our flexibility to our hospital partners so they choose who the best person is based on their capacity to assess. So what this allows now is a broad scope of physicians to be able to complete assessments. So if someone looks like they're a surgical candidate, that orthopedic surgeon will come in and do that interdisciplinary assessment. But sports medicine doctor, a family doctor, they can all be part of this depending on how that person is presenting in that medical. We've also embedded a functional recovery coordinator in every program. So these programs, you can imagine, they have that assessment. There could be an interdisciplinary treatment component. We have specialty consultations. We have mental health consultations. There could be surgical consultations, all within the program. So we wanted to make sure there was a person, that key component, to keep everything integrated. So us at WSIB know what those recommendations are and have a point of contact. So we've seen incredible success with that it keeps it all together, keeps that occupational functional lens, and allows us to have a contact for questions. And then our goal, as always, is to increase access across the province. I'll speak a little bit about mental health in the next slide and some of the changes there, because again, we've seen very big increases in those claims, and it's still that challenge on how do we best manage it, but we have expanded across the province and our partners. We introduced new programs. So we have a specific integrated pain program now. Within all of our specialty programs, and as well as our community programs, there's always that psychosocial, mental health, pain component that should be addressed. But what we saw as a gap is there are that component, small portion of people who need an intensive pain program when that's only limiting factor. So we introduced that program, as well as communicable illness with our learnings from COVID, to make that a permanent fixture. And we expanded neurological injuries. So not only mild neurological injury, but moderate, severe, and a spinal cord program. We're also pleased, because we went more into the Eastern region in our partnership with Ottawa Hospital, increase with French language services. And then finally, I think key point here in terms of what we ask and the difference between these services outside of OHIP is our focus and our mandate to support return to work. So what we ask our providers is to really focus on that functional abilities information so we can best support them and support their employers in getting them back to meaningful work. So we're not asking our healthcare providers to necessarily comment on, can you return to work or not? It's more, what can you do within your functional abilities so that we can help support them and find something that works for them. And this just gives a nice visual of all of our different programs here. I'll point out a couple of key features, being mindful to leave time for questions, but I think that the biggest benefit of this is expedited access. So if you think about our upper extremity, lower extremity, back and neck physical programs, somebody can have from referral to the time we get report is 10 days. When we talk about surgical access, they can have access to surgery within 15 days. So that's what really the benefit is of having this service, because we have that increased access and a timely access. We also see within mental health a lot of different options for types of assessment. That's where we saw barriers. We used to have a lot of psychiatrists, psychologists, allied health all involved in the assessment. It wasn't happening. We know quicker access gets someone into treatment faster. So we have options now for a rapid assessment, which is psychiatry and OT standalone within 10 business days. So I think that is one of the standouts when we're talking about access to these services and the ability to provide that interdisciplinary treatment and have those specialty consults as well at our fingertips. So that's a very high level of your overview. Happy to take any questions specifically about these.
Great, thanks so much, Jessie. Okay, I don't see any other questions in the chat, so people can use the chat or they can raise their hands and we can answer your questions. Or I can just talk about some of the questions that I normally get, or Jessie can, and stay. Heather.
Hi, thanks for your talk. I have a remaining question, and maybe it's case by case. What I struggle with is when I'm doing a Form 8 in the emergency department and I don't know what the patient's work duties are, and they're telling me they can't perform their duties at work. Is that enough information to put them off work, or I just list their modifications and the employer has to work around the modifications that I specify? And then does that get remodified by the caseworker? I'm curious to know, like, am I messing it up or is it okay? And how long do you put them off work for if they're telling me, no, I can't work? And then the case worker will just like fix it all once they get the
Yeah. No, I love that you asked this question, Heather. This is such an important question, and so with the residents, often we'll spend a whole session, like a whole morning, just filling out Form 8s, etc., and going through this. But to address your very core question, right? So what you're really asking is, what's my role here when I'm filling out a Form 8? What information am I supposed to put that's really going to help and facilitate, that person's recovery, return to work?
Yeah.
And so, and that's actually a very timely question too, because the CMA is redoing right now as we speak the policy on the physician's role and return to work. And one of the things that's really highlighted, and it's always existed, and it's partly because of the forms that create confusion. Like, what are the roles, right? So the roles of the healthcare provider, what's in our wheelhouse is to fill out the restrictions and the limitations, right? That's what and also put the diagnosis, right? Diagnosis, what treatment are they getting? And then on that second page, what are the restrictions and limitations, and provide a bit of information on abilities if you can too. That's really where our role ends, because whether or not the person can work is completely dependent on what accommodations are available for those restrictions, limitations, which we as healthcare providers will never know, right? We don't set foot in the workplace, so how could we ever know if they could be accommodated? You could have somebody that's non-ambulatory, and you'd say, okay, I guess they can't work as a carpenter, right? But if their employer says, hey, Joe, we just need you to answer the phones, and you know, you might not even have to come in. We just need you to answer the phones. Uh, that's an appropriate accommodation. The person can be successful, so they can return to work. But we would never know that as healthcare providers. So what a lot of the jurisdictions, WSIB has not done this yet, but a lot of the jurisdictions have actually taken the return to work question off their forms. They only ask restrictions, limitations. And so then when it comes back, then it goes to the employer, and the employer has a duty to accommodate to the point of undue hardship. So in terms of that conversation with the patient, what I would usually say is that I need to put your restrictions, limitations. That's what and so it may be like, if you can't be accommodated, then you won't be able to work. I totally understand, but I have no idea if they can accommodate or not. And the worker, the patient doesn't actually know either, because the employer doesn't know until they get the restrictions, limitations. So the short answer to your question is just put the restrictions, limitations, and that will go back to the employer, and then they can figure out if they can accommodate or not.
Great, thank you.
Yeah.
And out of curiosity, what's the timeline between the submission of a Form 8 and then when they are assigned a case manager who would be able to moderate, I guess, if there were discrepancies between the employer, employee, and the limitations?
Yeah, it's a good question. Jesse, do you know the answer to that? I think it's I want to say 24, but it might be 48 hours, but it should be processed within 24 hours.
Yeah,
Oh,
I
so
think that's the goal. Yeah.
Okay.
Okay, great. So I'm seeing some other amazing questions that are coming in here. Further information, what's the best site link to access as a starting point? If I wish to speak with someone directly, is there a mechanism? So there's a specific portion of the website which has gotten a lot better for healthcare providers. If you want to speak with someone directly, then you can call directly, particularly if they have a claim number, and speak directly to the case manager. That's going to be the most efficient means of getting that across. And so that's another question you see on the healthcare provider site. It will actually instruct you if you feel your patient would benefit from one of the programs like you've learned about today, then you can call the WSIB and let the case manager know that. They have to make the referral to the program. That's something that is still like an extra step. Like, you can't refer directly into the program like you would make other referrals. But if you call the case manager and say that you think the patient would benefit, then that's the most efficient way to do it.
I popped in the link to the programs just at the bottom there for everyone. And I have my contact if there's program specific questions, not claim related, but always happy to chat.
Excellent. Okay, I'm gonna just address this, and I know people may have to step away now at 1, but I will address these questions for anyone that's able to stay for a few more minutes. So, advice on dealing with the occasional patient who's reluctant to apply for WSIB. So this is a very common one. You know, the patient says, well, you know, I don't want to cause any problems for my employer, or I don't want to create paperwork, or it's just going to be a hassle. Sometimes they'll say, well, I have OHIP anyway, so it's not like I have to pay for my healthcare, so I don't want to file a claim. So the jumping off point there really as the healthcare provider is immediately you have to make sure that they are making an informed decision, right? And for them to make an informed decision, they have to know what they're passing up, right? If they don't file a claim. So essentially, if you're able to explain to them that the WSIB, by filing a claim, it provides far more benefits than they will get in the absence of having a claim. That's the first thing. Like, you have to make it important for them. What does this mean to me? So, you know, you can start with like things like the formularies, things like physiotherapy, OT, like these programs of care, etc. They have access to that when they file a claim. The wage loss benefits, you know, sometimes they'll say, well, my employer said they'll just cover me while I'm off anyway. But those wage loss benefits are quite important if somebody's going to be off work for a while, and sometimes you can't predict that, right? So it might seem like a minor injury, but what happens if there's a secondary infection? What happens if it's more complicated than they thought and they require surgery or something? Nobody has a crystal ball, so it really is very important for them to get the best care, most rapid access, expanded care benefits, and loss of earnings benefits. Really, like, so important and in their best interests. And the other thing that people will sometimes say is, I'm worried I'm going to get fired if I file a claim. Like, my employer is going to be mad at me. And so usually what I would say is, if that's kind of the relation, if you're concerned about that with your employer, I would be more worried if I didn't file a claim, because really it's very difficult to make that argument about dismissal and being fired because the employer you know, discriminated against you because maybe you couldn't keep up in terms of the rate of work, or maybe you're not getting better, or you're missing time or something like that. Then if you get fired, you can get a labor and employment lawyer, etc., and try and get your job back or sue them or whatever, but that's a difficult process. If you have a claim, it really does protect you from being let go from your employer. Like, they cannot let you go when you have an active claim or for a period of time after that. So that's actually the best insurance to keep your job by filing a claim, particularly if you're worried about you know, some repercussions. They absolutely, employers are not allowed to penalize you for filing a claim. So that's maybe a bit of a long-winded answer, but when I hear a patient doesn't want to submit a claim, it immediately tells me they don't have a good enough understanding of the system, and so it really is behooves us as healthcare providers to provide that education for them, so they're making an informed decision. Is it correct that if a Form 6 and 7 aren't completed, we don't get paid for completing a Form 8? No, that's not true. You'll always get paid for the Form 8. Yeah, so I mentioned that Form 6 and Form 7 is required to initiate a claim. A Form 8 alone does not do it, because ultimately it is the choice of the patient whether or not they want to establish a claim. The only exception there is with occupational diseases. Then a Form 8 alone is sometimes used to submit a claim, because it might be in a state or something even. So anyway, Form 8s can be used, and you will get paid for completing Form 8s. You won't get paid for completing 2 Form 8s. That's one thing. So a Form 8 is the initial report. After that, it's FAFs and Form 26s. FAF if the worker asks you to fill it out, or the employer. Form 26 if the WSIB asks you to fill it out. So you only get paid for the first Form 8. I've not been paid for Form 8 on more than one occasion. It might have maybe the person was seen in a merge or something, and the Form 8 was already filled out. I'm not sure, but if that happens, phone the case manager and let them know, because that if it's the first form that's being filled out, you should be getting paid for that. Am I missing? Does the WSIB reimburse the cost of crutches, slings purchased by the patient? Yes, but they need to let the case manager know, I think, Jesse, before they purchase
They-
it.
Yeah, they do. We do have preferred suppliers for those types of items, equipment and supplies. But if they have gone somewhere locally, it just has to think that has been approved by case manager. And then, yeah, we would reimburse them if they haven't used a preferred supplier, as long as it's approved. Great questions.
Yeah,
And-
great questions.
Sorry, John had a follow-up question, and I just want to make sure you did address it. So if we refer to PT, we should make sure it's one of the PTs listed on the WSIB website, or a practitioner we know is part of the program, not just any PT.
Yeah, so I think benefit is if they're on the directory, we know they're already registered, they have the qualifications, they know the program. They also get those rates, right, which is incentivized and far better than what our fee for service is. So we would promote those ones who are on the registry. However, people have choice in their care provider. So what I'd suggest, if somebody is saying, or there's somebody that you highly recommend because you know them, that's where my team can get involved. What we normally do is contact that physiotherapist or clinic and try to get them to register for delivering the program of care. We know it's best practice because it's evidence-based, it's that bundled program. Again, the fees are better, so that would be our best course of action. But we do always have a method within our fee for service to allow outside of that. We just try to promote that program of care. So usually when we talk to them, we can get them on board, and then they'll be on the directory for next time.
Thank you. I do have a follow-up question for the crutches. So if a patient comes into the emerge for their injury, its first presentation, you fill out a Form 8, they can't leave there without crutches, but yet they don't have a case manager yet because you haven't even faxed the Form 8. Do they pay for it and keep a receipt and later try to submit that? Or you're saying that it won't be approved at all because they didn't run it by a case manager before they made that purchase?
No, I would say and Dr. Thompson, you correct me if you have a different line of sight, but I think in general, that would be, they'd purchase it, it's not entitled. And then once they get entitlement for that, that's the only piece. Once they get the claim, we would reimburse. We see some reimbursement. We just want to try to remove out of pocket. But that's only once they have a claim allowance. So anything they've incurred before would generally be approved later, as long as the claim's been allowed.
Yeah,
So-
just tell them to keep their receipt.
Yeah.
Perfect. Thank you.
Yeah, it should be reimbursed. And the last thing I'll just say is these programs of care, we didn't really have time to get into it, but these are not things that are just developed by WSIB. So when a program of care is developed, it's done with a group of experts generally appointed by the different associations. So people like experts in the community that are involved in the treatment of patients with these injuries. And that expert committee comes up with the program of care. Generally, there's also researchers and specialist physicians, etc., all involved. So these are large groups that essentially sit around the table, bring the research forward, bring their experience forward. They come up with what the majority of patients will benefit from and should be included in that program and the duration, etc., etc. So that informs the development of the program of care, and that's why they're revamped every so often to keep up with evidence-based and current best practice. Yeah, and so that's why we really promote people getting treated within these programs. great questions. So I hope that that's helpful. Are there any others before we close out?
I'll speak up. So I'm just wondering, for programs that aren't necessarily available locally, is there any role for telemedicine? Just,
Yeah, we've been using virtual care a lot more. The good news is that these programs of care, because of our expanded access, generally we do have, I always use Red Lake as the example because we have 2 providers in Red Lake and everyone got very happy about that, but generally we'll have physical location. We do pay for travel because we do recognize the importance, because it is a return to work, OC rehab focus, the importance of getting out of your house and attending appointments as well. But in exceptional circumstances for physical injury, we'll support virtual. Mental health, we see it a lot more, that virtual care, so we support that. And then you heard about the virtual assessment option within our OHub, which is actually done a lot in terms of accessing that specific type and expertise of physician and from that person's community.
okay, perfect. I'm not seeing any last minute hands going up. So thank you so much for coming and presenting to our team. I know it was informative for me, and I'm sure it was for the rest of the group. And yeah, just the heads up, we do have one last set of rounds in June, and it will be Taylor Matson from the Public Health in Perry Sound, reporting on the district age-friendly community needs assessment that they recently done. So that'll be June 26th at noon for those interested. Otherwise, thank you so much for coming and sharing your knowledge with us.
Thanks for the invitation, Kathy, and thanks for all the great questions. And have a great day, everyone.
Thank you so much.
Okay. Bye.
Thanks a lot, Aaron and Jessica.